Okay, good morning, everyone. Friday, February 20th, why don't we get started? And I'd like to welcome everybody to this week's departmental grand rounds. We have the distinct pleasure of hearing from one of our neuro-ophthalmologists at the University of Toronto, that is Dr. Cindy Lam. Dr. Lam focuses on not just neuro-ophthalmology, but also comprehensive ophthalmology and cataract surgery. And she is a lecturer in our department at the University of Toronto. She has practices both at St. Joseph's Health Centre in Toronto and the Kensington Vision and Research Centre and operates out of the KEI and University Health Network. Dr. Lam completed her residency only a couple of years ago here at the University of Toronto, where she had the pleasure of serving as a chief resident. And following that, she pursued a fellowship in neuro-ophthalmology also at the University of Toronto. Since graduation, Dr. Lam has contributed greatly to our medical student and resident education, and she currently serves as a site director for the surgical residents at the Kensington Eye Institute and participates with our residency program committee here at the U of T. So, Cindy, thank you so much for putting together grand rounds this morning with Jim and Irina, and the floor is yours.
Thank you very much. It's our privilege today to present a couple cases we came across in practice where the diagnosis was not easy to make, but interdisciplinary collaboration helped to make the diagnosis and help with management for the patients. So without further ado, I will pass the floor to Jim, who's one of our STAR PGY2 residents, and he will present our first case today.
Thanks, Dr. Lam and Dr. Rai. I'm just going to share my screen. All right, so thanks everyone for joining Grand Rounds. I'm Jim, I'm one of the PGY2s. I'll be presenting on a case of migraine with visual aura and its association with cardiac pathology. So we had a 43-year-old male who's an IT analyst, and he had a past medical history of migraines, gastric ulcer, cholecystectomy, and he was also an ex-smoker. He was having migraines since his late adolescence, and he described it with very classic symptoms. His visual auras consisted of zigzag lines and tunnel vision, which were followed by unilateral headache with some nausea, vomiting, photophobia, and phonophobia. He did not take any medications, and he did not have any ocular history. So one night he had symptoms that were similar to his usual visual aura, but quote unquote, the sparks were more intense, and they were not followed by a headache, which was unusual. His symptoms lasted around 20 minutes and receded, but some sparks persisted in his left lower visual field, which led him to present to St. Michael's Hospital Emergency Department the next morning. He had a CT head that was done in the emergency department, which was unremarkable, and he was subsequently referred to an ophthalmologist at St. Mike's. Ophthalmology exam was normal, and his OCT and RNFL and GCC were also unremarkable. However, when we did do a 24-2 visual field, it showed the left central defect that respected the horizontal and vertical meridians concerning for a left lower quadrantopia. So because of our concern for stroke, we referred him to a neurologist at St. Joe's who ordered two unenhanced MRIs of the brain, which showed small chronic infarctions of the left cerebellar hemisphere, but no stroke in the occipital lobe. He was then referred to stroke because of these chronic infarcts, and he was started on aspirin or rosuvastatin. And as part of his stroke workup, he had an echocardiogram which showed a patent foramen ovale, and the rest of his workup was otherwise unremarkable. Since the neurologist at St. Joe's was unable to explain his left homonymous quadrantopia, he was referred to us in neuro-ophthalmology service, and we decided to do a 10-2 visual field. So here on the 10-2 visual field, we can see a further delineated central left lower homonymous quadrantopia. So because of our high suspicion for stroke, we ordered a third MRI this time, and the MRI was done at a tertiary center. Again, it was read as normal in terms of no occipital lobe stroke by the general radiologist. But because we have a consistent quadrantopia demonstrated in our high suspicion, we asked for a second opinion from a neuroradiologist with dedicated attention to the tip of the right occipital lobe. And the neuroradiologist looked diligently at all past three scans, and indeed there was a small cortical infarct at the tip of the right occipital lobe. And this was in fact present on all three previous MRIs that were ordered, and they were just never commented on. So this was a T2 FLAIR axial sequence, and you can see this was from the first MRI that the patient had, and you can see a hyperintensity at the tip of the right occipital lobe as indicated by the red arrow. So in summary, our patient had three separate MRIs, and all were read as no occipital lobe stroke by the general radiologist. However, when we consulted a neuroradiologist later, we confirmed that the patient did have occipital lobe stroke in all three previous MRIs. Unfortunately, this neurologist at St. Joseph's did not have access to formal visual fields, but we did, so that helped us guide the neuroradiologist to look at the tip of the right occipital lobe. In terms of what happened to our case, he was eventually referred to a cardiologist and he underwent a PFO closure in 2020, which was around 1.5 years after initial presentation, mostly because he had a stroke of unknown origin. As an adjunct benefit from him, he had a dramatic reduction in his frequency of migraines with visual auras from 2 times a month to 1 to 2 times per year. He was very happy about this, and this was stable until his most recent follow-up in 2024. So the main teaching points from this case was that the tip of the occipital lobe, or i.e. the occipital pole, represents the central 15 degrees of the visual field. Lesions at the occipital pole cause small, dense, contralateral central scotomas, typically with sparing of the peripheral field. And if a patient comes in with a suspected central visual field defect that is equivocal or not picked up on a 24-2, then you can consider doing a 10-2. As you can see in our case, lesions at the occipital pole may be very subtle and missed, especially when the clinician who requests a scan does not have access to formal visual fields and cannot provide anatomic guidance to the radiologist reading the scan. Thus, it is important to include anatomic suspicion when we're doing our neuroimaging request, and also to consider direct discussion with neuroradiology. So moving on, we're going to talk a little bit about migraines. Migraines affect around 15% of the general population, and around 30% of people with migraines get auras with their migraines. There's a very specific definition of migraines and auras by the International Classification of Headache Disorders. We won't go into the full details, but generally headaches last around 4 to 72 hours, and they're defined by multiple characteristics, including laterality, quality, and accompanying symptoms. Aura symptoms should be fully reversible, and in addition to being visual, they can also be sensory, speech-related, motor, or brainstem. And aura similarly is defined by certain characteristics such as changes in intensity, positive versus negative features, and accompaniment with headache. And migraines with auras cannot be better accounted for another diagnosis in this classification system. So in terms of migraines with stroke, many meta-analyses of large observational studies actually show robust associations between migraine with visual aura specifically and ischemic stroke as well as hemorrhagic stroke. For ischemic stroke, the relative risk ranges from 1.6 to 2.3, and for hemorrhagic stroke, it's around 1.7. And in terms of the evidence for migraine without aura, it's varied, but some of the meta-analyses show that there's no association, it's non-significant. So in general, there seems to be a higher risk in women who are under 45 years old and have late onset migraine with aura, very active migraines, or have very frequent attacks. Interestingly, ischemic stroke occurs 7 years earlier in women and 5 years earlier in men with migraine compared to people without migraine. So there have been many proposed mechanisms for dissociation between migraines and stroke, some of which include cerebrovascular damage, some systemic sort of endothelial dysfunction or vascular permeability, a shared genetic predisposition, some sort of hypercoagulability, including increased platelet aggregation, increased prevalence of a PFO, as we talked about, use of NSAIDs in the treatment of migraine, as well as vascular risk factors that coexist between or that are shared between people with migraine as well as people with stroke. So migraines also have an association with heart attack, and meta-analyses similarly show a slightly raised risk of angina without myocardial infarction, uh, absolute myocardial infarction, as well as cardiovascular mortality. And again, these associations are strongest with migraine with aura and less strong or non-significant for migraine without aura. And there was a large cohort of female healthcare professionals over 45 years old, and they were followed for several years. And the authors looked at the outcomes of MACE, which included myocardial infarction, stroke, as well as cardiovascular mortality. And they found that in this cohort, large over 30,000 people, they found that active migraine with aura was associated with MACE, but not migraine without aura, and that even comparing to traditional risk factors, migraine with aura was more strongly associated with MACE than obesity and hypertriglyceridemia. Similar association is arterial hypertension and hypercholesterolemia, and just only weaker than diabetes and smoking when it comes to MACE. And so there have been lots of proposed mechanisms for the association of migraine and myocardial infarction as well. One of them is similar to stroke, is that there is an increased prevalence of common comorbidities due to shared environmental or biologic features. The controversy is that multiple studies have adjusted for these risk factors when doing statistical analysis, and that some in vivo studies show similar coronary calcification between people with versus without migraine, which disproves that hypothesis. Indeed, based on large observational studies, people with migraine have higher rates of hypertension, hypercholesterolemia, metabolic syndrome, and smoking. And in particular, women with migraine have higher rates of gestational hypertension and preeclampsia. Another proposed mechanism is systemic endothelial dysfunction, but some studies found similar peripheral and intracoronary endothelial function between people with migraine and controls. Thirdly, there is a known higher prevalence of migraine in non-obstructive coronary artery disease, which is thought to be related to coronary vasomotor dysfunction. So when this vasomotor dysfunction occurs, there's thought to be increased microvascular resistance and impaired vasodilation, which leads to decreased coronary flow reserve. But some studies looking at coronary flow reserve between people with migraine and controls find contradictory evidence. Some show that there's decreased coronary flow reserve, some show that there's similar flow reserve. So overall, there's no robust mechanism found yet for the association. But in summary, we have several large prospective observational studies that suggest that migraine with aura, but not migraine without aura, slightly increases the risk of ischemic stroke, ischemic heart disease, as well as cardiovascular mortality even. And there appears to be maybe a higher risk if there is a higher attack frequency of the migraines. The mechanism is unclear. Perhaps there is some sort of systemic vasculopathy or coagulopathy. It might be iatrogenic from the treatment of migraine. There may be shared environmental or genetic factors that cause both people with migraine and people with cardiovascular disease to get those to have traditional vascular risk factors, or there may be an inverse relationship in which one of the cardiovascular diseases actually causes migraine. Putting this all together in terms of what the international guidelines recommend, there is no specific treatment recommendations for people with aura, migraines with aura, but in these patients, generally, we should recommend that they avoid estrogen-containing contraception as well as cease smoking, and that they should undergo routine cardiovascular screening and optimization with their primary care physician. So we're going to focus a bit on the patent foraminal value, or PFO, which is what our patient had. A PFO is a physiologic opening between the right and left atria during fetal development that allows oxygen to bypass the fetus's non-functioning lungs. So it normally closes after birth, but it stays open in around 20 to 30% of adults. So around 25, a quarter of all the general population has a PFO at this moment. The mechanisms by which PFO can cause stroke include paradoxical embolism, which is which a clot in the venous system goes into the right atria, and then instead of going to the pulmonary circulation, it directly crosses into the arterial circulation through the PFO and then causes a stroke. In terms of, there can also be an in situ thrombus formation. So instead of a distant venous clot coming into the heart, thrombus can directly form in the atrial tunnel that's formed by the PFO. So studies have found that the prevalence of PFO increases to around 50% in patients 60 years or younger with an embolic stroke of undetermined source, which is otherwise termed a cryptogenic stroke. And given that up to 30% of all strokes are cryptogenic, the numbers work out to around 5% in young adults and 10% in middle-aged adults of all ischemic stroke is actually directly caused by a PFO. So why do guidelines recommend PFO closure uniformly in all patients under 60 years of age with a cryptogenic stroke? So PFO closure has been consistently demonstrated in RCTs to lower the risk of recurrent ischemic stroke by more than half compared to medical treatment alone. And the relative risk is the exact number is around 0.44, so a bit more than half. There's kind of less evidence, less RCT evidence for patients over 60 years of age. So what guidelines recommend is that you can consider it if there are high-risk features of the PFO, such as it's a large interatrial shunt, or the patient also has a history of known history of venous thromboembolism. So the picture on the left, you can see by the red arrow how a clot may travel from the right atrium through the PFO into the left atrium and then enter the arterial circulation. And then the picture on the right shows how a PFO is closed. A catheter is inserted through the femoral vein, through the inferior vena cava, into the right atrium, and a device is deployed across the PFO and to close it. So now moving on to association with between PFO and migraine. PFO also has an elevated prevalence in migraineurs with aura, around 30 to 50% compared to, again, 25% in the general population. And meta-analyses of observational studies show that people with PFO have up to 5 times the odds of having any type of migraine, have more than 3 times the odds of having migraine with aura, have more than 3 times the odds of experiencing aura when they have a migraine, but are not more likely to have a migraine without aura. And those with any migraine also have an elevated odds of having a PFO themselves. So in addition to that, people with migraine are more likely to have a permanent PFO rather than a latent PFO, whereas a permanent PFO is having a shunt at rest versus a latent is only having a shunt with Valsalva maneuver. And they're also more likely to have a large PFO than a smaller PFO, which is defined as 4 millimeters of diameter. There seems to be a dose-dependent relationship in which people with more frequent auras tend to also have a greater degree of atrial shunting through their PFO. Now, again, multiple mechanisms have been proposed for why PFO has a close association with migraine. Some have hypothesized that there are anatomical abnormalities such as embryologic remnants of venous valves that exist more frequently with PFO migraineurs with aura, and these may prevent spontaneous closure after birth of the PFO. Related to this, there may be a hereditary association between PFO and migraine. Another mechanism is that there may be passage of microemboli from the venous into arterial circulation with or without shunting of deoxygenated blood through the PFO. These may cause brain microinfarcts and cause cortical spreading depression, which is the pathologic basis of migraines. Studies have shown that air microembolism can trigger migraine with aura directly and also cause EEG alterations. The hypoxia from the mechanism above can increase the expression of plasminogen activator 1, which may cause a positive feedback loop and increase the chance of paradoxical microembolism. And there's also been shown to be increased platelet activation of migraineurs, which can promote the release of pro-inflammatory cytokines and contribute to pain signaling in migraines. A third mechanism is that vasoactive chemicals, which are implicated in migraines, these chemicals are normally deactivated by enzymes in the pulmonary capillaries. But when they enter through the PFO, they can skip deactivation in the lungs, and they can travel up to the brain to directly activate the trigeminal vascular system and cause migraine. So in terms of what we can do about this to help people with migraines, RCTs have also been conducted looking at the effect of PFO closure compared to medical treatment for migraines alone versus sham procedure. To date, around 5 RCTs have been conducted, and 3 of them have low risk of bias, but the other 2 have overall high risk of bias. You can see the last column on the right. The first and the fifth RCT have a high risk of bias. So when the meta-analyses put this together, they found that PFO closure did not help with complete resolution of migraine. So there was no effect on migraine cure when we closed the PFO. However, there was an effect when we looked at frequency of migraine attacks, as well as number of migraine days per month. A PFO closure did cause a decrease in the number of migraine attacks. And this is another individual participant meta-analysis this time of two of the higher quality RCTs that give us specific numbers about what PFO closure does. So so when looking at any type of migraine, PFO closure leads to 1.2 less days of migraine, 0.6 less attacks per month, as well as 8.3% more cure, as in 8.3% more people get complete cessation of migraines. When we look at the subcohort of migraineurs without aura, the only significant outcome that remained was a decrease in the number of attacks per month, which showed that perhaps PFO closure has less of a beneficial effect when the patient only has migraines but not auras. So in summary, PFO is more strongly associated with migraine with aura than migraine without aura. PFO closure likely decreases the frequency of migraine attacks and may lead to complete resolution of migraines even, but does not appear to affect headache-related disability as assessed by standardized questionnaires. And complications of PFO are rare, mostly minor and temporary. They include things like perioperative atrial fibrillation, access site infection, or bleeding. So what does this all mean for us? PFO closure, without a doubt, is recommended for cryptogenic stroke in patients under 60 years of age. However, right now, there is no role for the routine screening or treatment of PFO for migraines without stroke. So if you, as an ophthalmologist, if you get a new patient who has migraine with aura, you can inquire about personal and familial cardiac history. If the aura is atypical or frequent, and the patient has a personal or family history of anatomic cardiac abnormalities or venous thromboembolism, then you can consider sending them for PFO screening. PFO closure does have the adjunct benefit of decreasing the frequency of migraine with aura, probably, but right now there's not enough evidence to recommend it as standard treatment in the absence of stroke. So we would only recommend, for now, still PFO closure uniformly if patients have stroke. Thank you very much.
Great, Jim. That was an excellent presentation. I think we all learned quite a bit there, a little bit outside of our usual realm, and very, very interesting. There's a couple questions here in the chat box. So, from Dr. Brent, do these findings for migraine with aura also pertain to ocular migraine, where there is aura but no or low grade headache?
I can speak. So yeah, I can speak to that. It's the studies right now really only looked at migraines with aura, and they didn't even specify specifically visual aura. So a large majority were probably visual aura, but some of the patients in the population that were studied could have been sensory or brainstem or other types of motor aura. We don't really. I guess the answer is we don't really have strong evidence if they only have the aura without a migraine. Um, um, so that's not been studied that much.
Good, thank you. And then from Dr. Cates, in those patients with a surgically closed PFO, do they need long-term anticoagulation because of the implant?
So our patient ended up just staying on aspirin. I believe you don't need like a DOAC. I think an aspirin, like a low dose aspirin, is fine. So not all patients uniformly need um, like anticoagulation.
I can take that as well. So I usually the patients will stay on short-term anticoagulation as standard, but if they have other risk factors like thromboembolic events in the past or atrial fibrillation, then they may stay on long-term therapy. And then in terms of the question from Dr. Brent about migraines or auras without the migraines or the headache part, I have seen studies where the uh, risk of having just the aura without the migraine still lends to the risk of having higher stroke and cardiovascular risks.
Okay, thank you, Jim. I will say, so Cindy Lamb and I were medical students together a long time ago, and I have forgotten how high the prevalence of PFO is. 25% is actually a very big number if we're thinking about the general population, right? So that is fascinating. And the other comment I will make is in today's day and age, you can't go a day without hearing about AI. And I feel like AI might have helped pick that up on those first three MRIs. And I think we're going to see um, some introduction of AI to imaging pretty soon. Irina, let's go to your presentation.
Thank you so much. I'm just going to share my slides.
While she does that, I will mention, if you haven't already, you guys should all try throwing Mac OCTs into the AI chat box. They can be totally impressive and totally off at this point.
Can everyone see my slide deck?
Yes, we can. Go ahead, Irina.
Okay. So, hi, my name is Irina. I'm a PGY2 at the Department of Ophthalmology at UofT. And Dr. Lam and I are going to be presenting on a curious case of vision loss. So we'll start with a case summary. In July 2025, we received a referral for a 68-year-old Asian female who had visually significant cataract. The referral from her optometrist specifically said visually significant cataract, much worse in the left eye than the right. On history, she noted slowly progressive vision loss over the last 5 years, but it had gotten worse in the last 6 months in her left eye. On exam, her visual acuity was Snellen 20/40 in the right eye and 20/150 in the left. There was no RAPD, but on slit lamp exam, she did have bilateral cataracts, worse in the left than the right. On fundus exam, she had a healthy appearing optic nerve on the right, and on the left, it was quite a hazy view due to the PSC. She eventually underwent cataract surgery about 3 months later, and on her post-op week 1 visit, she actually noted minimal improvement in her vision in the left eye. And in fact, her visual acuity was now hand motion in the left eye. The view to the fundus was now more clear once the cataract had been removed, and she was noted to have very subtle nasal elevation of her optic nerve without pallor, and there was a 3+ reverse RAPD. Visual fields were obtained at this point, and she had generalized depression in her left eye, as well as these losses in the right eye. Her RNFL also showed some subtle elevation in the left eye compared to the right. On further probing, she commented on this recent severe left-sided headache she was having, and actually noted an episode of severe left-sided headache 2 years ago, which was investigated with a CT scan, and that was found to be unremarkable apart from an incidentally enlarged left parotid gland. Her further past medical history was non-contributory. She had some GERD, dysphagia, overactive bladder, and she had had some CT chest done, which commented on bronchiectasis and some post-inflammatory changes, but otherwise nothing contributory to her presentation today. So at this point, I just wanted to pause and just give the audience a chance to think about what the most likely diagnosis is at this point. Is it 1, GCA? 2, NAION, 3, optic neuritis, 4, retroorbital mass causing compression, or 5, something else. So just kind of think about what's on the top of your differential at this point. The second question I have is, what investigations would you order? Would you get a CBC, ESR, CRP? Would you get a CT orbits with contrast? An MRI orbits with GAD, infectious screening, all of the above, or none of the above? This is just NAION. So at this point, investigations were ordered for her presumed optic neuropathy. We got a CBC, ESR, CRP, and inflammatory workup. So ANA, ACE, ANCA, infectious workup, VDRL, MOG, and NMO antibodies. We also ordered an urgent CT orbits with contrast while awaiting for an MRI orbits with GAD. Some of the workup had started to come back, and her P-ANCA was noted to be elevated. Unfortunately, the CT was delayed because the machine was broken. But eventually, 1 month later, she did complete an MRI, and I just wanted to show you the images here so you could take a look briefly. The MRI report commented on this abnormal circumferential enhancement along the dural sheaths of the intraorbital and canalicular segments of both optic nerves. It showed abnormal signal and enhancement within the bilateral inferior orbital fissures and pterygopalatine fossa. and diffuse dural thickening and enhancement involving the floor of the middle cranial fossa. So here, this is just showing the areas of enhancement that were commented on the MRI report. The image on the left is a coronal T1 weighted post-GAD fat suppressed, and the image on the right is an axial T2 weighted fat suppressed MRI. So given these MRI findings, now what do you think is on the differential here? Is it demyelination, GCA, syphilis, sarcoidosis, IgG4, granulomatosis with polyangiitis, lymphoma, or no idea? So the part that I left out in the initial MRI report, this was the differential that was listed by the radiologist that read the MRI. The differential diagnosis for these findings were listed as IgG4, GPA, sarcoidosis, or lymphoma. So back to the case, the patient has now returned for follow-up after her MRI has been completed. Her visual acuity at this point has dropped from hand motion to no light perception in the left eye, and she's now complaining of new blurry vision in the right eye. Up until this point, we had tried to convince her to be admitted to hospital for an expedited workup, and she had been reluctant to do so. But now, given this acute drop in her vision, she's finally convinced to be admitted to hospital. The goals of the admission are to involve multidisciplinary teams, so neurology and rheumatology, to help expedite a workup. And as part of the workup, a goal is to identify a lesion that could hopefully be biopsied to identify the source of her optic neuropathy and to delineate between lymphoma versus other inflammatory etiologies. Finally, a goal is to be able to initiate high-dose steroids for her to try to preserve her vision once lymphoma had been ruled out. Given this particular presentation, though, as she started complaining of new blurry vision in the right eye, we did have some concern that that would continue progressing. So she was started on at least a prednisone 40 milligrams to try to preserve the vision, but obviously wanted to expedite a workup in hospital for her. So at this point, she's been admitted to hospital. Rheumatology and neurology have been consulted. Rheumatology feels that there are no clear indications of an autoimmune rheumatic disease going on. They feel like ankylosing is a possibility, but it's unusual because she lacks some of the other manifestations of ankylosing. IgG4 related disease is also on the differential, but they feel malignancy needs to be ruled out here. Neurology's opinion, you can guess she needs an LP. And both agree workup needs to be done to hopefully identify a lesion that could be biopsied for her. So going back to lumbar puncture, I just wanted to revisit the components of CSF analysis that we look at once an LP is completed. So we look at color, opening pressure, cell counts, so RBCs, white blood cells, differential. We look at glucose, protein, gram stains, and then there are other tests we can order like a paraneoplastic panel, cytology, flow cytometry. And this is just a table I wanted to put up of the normal values of CSF components for adults, children, and neonates. Looking at these components in a little more detail, with white blood cells, they're increased in inflammatory CNS diseases as well as malignancy. Protein is increased in cases of blood CSF barrier dysfunction like meningitis, malignancy, inflammatory diseases. Glucose can be normal in inflammatory conditions. It tends to be more decreased in bacterial or fungal infections as well as malignancy. So that's an important marker to help us distinguish between an inflammatory versus malignant cause of her vision loss. Cytology looks at atypical cells that it can be characteristic of malignancy like lymphoma, meningeal mets, brain tumors. And flow cytometry allows for quantitative and qualitative assessment of cells based on their physical properties and immunophenotype. So it aids in diagnosis of CNS malignancies, lymphoma. This is just a summary slide of all of these investigations she's undergone in hospital at this point. So her blood work, as you'll remember, her p-ANCA ended up being positive. Her CSF was normal for glucose cytology, flow cytometry, but it showed a very elevated white blood cell count of 169, and you'll see that the normal is less than 5. Her imaging was negative for vasculitis on CTA head and neck, and her chest, abdomen, pelvis didn't show any evidence of malignancy or sarcoidosis. She's also got a repeat MRI brain and spine with GAD done, and it comments on abnormal bilateral perioptic nerve enhancement, and it's commenting on new increased signal in the left intracanalicular optic nerve now. There's worsening of the smooth dural thickening more on the left than the right, and there's this new extraaxial collection underneath the dural thickening over the left frontal convexity. Okay, that was a lot of investigations. What is the summary that we have so far? She has a hypertrophic pachymeningitis with a progressive optic perineuritis bilaterally, and she has a left optic neuritis. Her blood work and CSF identify increased inflammatory markers, but there's no clear evidence of malignancy on her imaging or her CSF. In particular, lymphoma, which is something we wanted to rule out as part of the investigations, although this can be very difficult to diagnose. And there's no systemic evidence of vasculitis. The other issue is that as part of all these investigations, there's still no evidence of a clear lesion to biopsy. So what ends up happening? Well, she underwent a dural biopsy. The biopsy was uneventful, and the pathology has come back, and it showed, in the context of positive MPO serology, the findings are compatible with ANCA-related hypertrophic pachymeningitis without definite features of vasculitis, no evidence of infectious, neoplastic, or granulomatous disease. What is hypertrophic pachymeningitis? So this is a chronic inflammatory process that's marked by localized or diffuse enlargement of the dura. It can be idiopathic, or it can be secondary to other causes like immune-mediated processes, infections, or malignancy. The thickened dura can cause mechanical compression of vascular structures and nerves, as well as meningeal inflammation. So it can lead to intracranial hypertension, optic neuropathies, other cranial nerve palsies, or spinal cord compression. It's quite rare, the incidence of 0.949 per 100,000. About 50% of cases are idiopathic, and again, the MRI findings show dural thickening, but often you do need a biopsy to confirm the diagnosis. Patients frequently present with headaches, cranial nerve palsies, optic neuropathy being a very common one, and often they're very responsive to steroids, but they can recur or relapse on immunomodulatory therapy, unfortunately. And here I'm just breaking down some of the different causes of hypertrophic pachymeningitis based on those different categories that I talked about earlier. So, immune-mediated, or these are some of the ones we had on our differential. There's ANCA-associated vasculitis, IgG4-related disease, sarcoidosis, rheumatoid arthritis. There's infectious causes like syphilis, tuberculous meningitis, cryptococcal meningitis, and malignancy, so lymphoma or meningiomas. This was just a case series of different clinical features and etiologies of hypertrophic pachymeningitis of 33 patients. And you can see very common presentations here where about a third were presenting with headaches and cranial nerve palsies, but other findings were, cognitive impairment, delirium, motor and language impairment. And in this particular case series, interestingly, half of the etiologies were neoplastic and 24% were inflammatory autoimmune. I did a literature search of optic neuropathies associated with hypertrophic pachymeningitis, and I came across 33 cases aged 28 to 79. And the highest etiology in this review was idiopathic in 39% of cases. And treatments were predominantly, like 76% of cases had received steroids, but then many patients were transitioned to other immunomodulatory treatments like cyclophosphamide, azathioprine, rituximab, etc. Our patient specifically had hypertrophic pachymeningitis secondary to an ANCA-associated microscopic polyangiitis. So, MPO is an idiopathic autoimmune disease characterized by systemic vasculitis affecting the small blood vessels. It is associated with ANCA antibodies, and it's a subset of primary systemic vasculitis. The disease commonly affects the renal capillaries, pulmonary capillaries, and other systemic capillary beds. So patients very frequently have renal manifestations up to 80 to 90%, as well as pulmonary involvement and skin lesions. Um, Neurologic involvement is possible. CNS involvement is rare. And in particular, there's only a number of case reports that I came across of MPO associated with hypertrophic pachymeningitis. So it's quite rare. And what made the diagnosis in our patient even more challenging was they never actually had any renal or pulmonary disease. It was purely CNS involvement. So the treatment of hypertrophic pachymeningitis is truly targeted towards the etiology, but oftentimes initial therapy has been with moderate to high dose corticosteroids, followed by steroid-sparing immunosuppressives. So these can be like cyclophosphamide, azathioprine, methotrexate, mycophenolate, etc. And rituximab can also be administered in cases of severe disease. Our patient, once she'd undergone the lumbar puncture and biopsy, was treated with 5 days of IV solumedrol. An MRI brain with GAD was repeated 2 days after steroids were initiated, and it was shown to be stable. Luckily, her headaches actually resolved, and the vision in her left eye had improved to count fingers. And the nerve was no longer elevated, but there was trace pallor, and the right eye's vision was stable. She was discharged from hospital and ultimately transitioned onto a prednisone taper with a plan to start rituximab, guided by outpatient rheumatology. And she has a repeat MRI pending next month. And just wanted to show the RNFL here 1 week post treatment. You can see the RNFL has decreased in the left eye compared to before she was admitted to hospital. And here there's more thinning now. And these are the visual fields for her right eye, and you can see improvement 1 month post treatment. This is my references, and thank you so much for listening.
Thank you. Great presentation. I mean, that's not an uncommon thing that we all get as comprehensive ophthalmologists and cataract surgeons. You know, it starts off as a much denser cataract in one eye, and that's just the beginning of the story, because when they come back, you're not getting the result that you expect. Cindy, anything to add to that case?
Yeah, this is a tricky diagnostic case for me. I think the management is still ongoing. She just transitioned to rituximab and she's getting a repeat MRI next month. So hopefully we'll see some improvement. I think for her, the really high MPO antibody kind of helped cinch the diagnosis initially. I mean, the sensitivity and specificity of MPO antibody is close to 98 to 99%. So when it's positive, the patient, most likely has this MPA, microscopic polyangiitis condition. However, what I found challenging with this case is that rheumatology is very good at treating rheumatological conditions when there are pulmonary renal involvement, but when it's just CNS involvement, it's really hard to cinch the diagnosis on that and to convince them to start treatment unless you have a very solid background of investigations to help them be confident in the diagnosis. So I think that's eventually why we were pushed towards the dural biopsy, which was also reassuring because it didn't show signs of cancer. CNS lymphoma is traditionally very hard to diagnose. Even on LP, I think the yield of urocytology is only about 30% at best. So sometimes you might need, if there's clinical suspicion, repeat LPs to try to look for CNS lymphoma. But I think this was a great learning case where there was multiple services, neurology, rheumatology, neurosurgery that had to be involved to help this patient not lose vision in her other eye. Sorry, I think you're, yeah.
Yeah, I'm on mute. I should know better by now. From the previous case, I think you had a couple comments about ocular migraine. Maybe you can just make those to the crowd as well.
So I think we do commonly see referrals from other referring physicians or from the emergency department, even of patients presenting with migraines with visual aura or just the ocular migraine part. As Dr. Brent alluded to, a lot of retina specialists sometimes get that referral as well. So an ocular migraine without headache would be considered an atypical migraine. And within that category, those patients do carry a higher risk of ischemic stroke, especially if they're women under the age of 50 or 45, as Jim has alluded to, or they have a history of thromboembolic events. So I would consider those patients. I would carefully take a history, asking if there's history of smoking, contraceptive use, history of family history of cardiovascular events or thromboembolic events or stroke. And if that's the case, I would ask the patient to see their family doctor for sure to be optimized from a cardiovascular standpoint. Although most of the time you can reassure patients that this the etiology is benign. They're not going to lose vision permanently from it. These patients do carry higher risk of cardiovascular mortality and stroke. So it should be part of their discussion and workup.
Great, thank you. And I will echo what Dr. Lutchman has said in the chat. I think those are both excellent cases and great presentations. So Cindy, Jim, Irina, thank you guys so much. We don't have any further questions, so we will conclude rounds a few minutes early. Thank you everyone for joining. We'll see you next week.